Hello everyone, welcome back to Clinical Cousins YouTube channel, where today we're going to go over some of the basic concepts that we need to know, that we need to understand what is going on in a heart attack, which is also called an acute myocardial infarction, or you'll also see it listed as an AMI. So basically, the thing that we need to know is that an acute myocardial infarction is the last stop on the bus. So first we're going to see ischemia, then we're going to see an actual injury to the cardiac cells, and then lastly there's going to be some death of the cardiac cells. This is irreversible, game over, never going to get that function back. So the easiest way to understand this is with a scenario. So let's say that hypothetically I gave you a patient who's been having some chest pains intermittently, but the pain has always been resolved with some sublingual nitroglycerin tablets. So this has all worked until now, but your patient took one dose for every 5 minutes for a total of 3 doses in 15 minutes before calling the ambulance and arriving at your emergency department. So this patient comes in, they're going to have some EKG changes. So let's take a look at exactly what happens in the different stages of myocardial ischemia, injury, and infarction. So let's take a look. So let's say that we take 3 serial EKGs that while our patient is staying with us. So first we have ischemia. So this is when the heart is just not receiving enough blood, or in other words, a great way to think about this that I heard somebody else say was the heart was working hard and not getting paid enough. So when the heart gets angry at us, it starts to hurt. So basically our heart is working hard like it always does up until the day you die, but for some reason there's a blockage in the coronary arteries, or it is spasm, so we are not getting the correct amount of blood to our heart muscle. This is called ischemia. So what does ischemia look like on the EKG? Well, this is shown on the EKG by a slight ST depression and a slight inversion of the T wave. So let's say the emergency department was on a staff strike and our patient got no help, so the ischemia worsened into the point of injury. So when the myocardial cells don't get enough blood for a long enough period of time, they become hurt or injured. So these cells are basically on strike. They're not going to work for us, but they would return if we could just pay them with a little bit more blood. So this shows up on the EKG as a slight ST elevation with an inverted T wave. Okay, so our patient has had really bad luck. They have not received any help. The heart cells are fed up and they die because they did not get paid with any blood money. So this is called an infarct. This is a very bad situation. These cells are never coming back. This means that our patient will never regain the function of those cells ever again. In fact, that portion of the heart that was infarcted will also be at a greater risk for rupture later on in life. And if that happens and you're not in a hospital, it's pretty much game over. You're not going to win that battle. So basically, what does an infarct look like on an EKG? Well, it looks like what you've probably seen in your exams, what you've probably seen on TV. It's that classic ST elevation or tombstoning with a deepened Q wave and an inverted T wave. So this is a bad sign. It's too late. This is a late sign. This is our last step on the bus. So we need to save as much heart muscle as we possibly can. We can't save the infarcted tissue, but what we can do is we can restore the blood flow so that we can restore function to these injured and ischemic heart cells. So basically, a great golden rule of heart attacks is to treat chest pain or any other symptoms or any suspicious EKG changes like that patient is having an active heart attack until it can be proven otherwise. So don't always just assume that it's their gastroesophageal reflux disease acting up. If they have EKG changes and substernal chest pain, take a closer look. You might be able to catch an MI that no one else did. So if you practice by this rule, I promise you that you'll save yourself, you'll save some patients, and you'll save your patient's family some heartache, pun intended. So we've probably heard of the term reciprocal changes thrown around in the hospital or medical TV show, but what is it actually? Well, the easiest way to understand this is that we have to understand that our leads are basically like little eyeballs that are looking at the heart from different directions. We know this from our previous videos. But the golden rule is that leads that are exactly 180 degrees from each other can see the same damage in the heart, but they will look like it's the exact opposite. So basically it's like looking in a mirror. So that's why I always say that reciprocal changes are basically just mirror images. So for example, if we're going to look at our patient's EKG in our scenario and we're looking at lead 3, we can see that they have some ST elevation. We see that there's inverted T waves. So what will this look like in our AVL, or our reciprocal lead? So if we saw some ST elevation, we see that this is mostly positive. Then if we see some mostly negative or some reciprocal changes in AVL, then we are going to say that that is the mirror image that we are looking for. It's some reciprocal changes, so that means that there's likely some damage that is going on in the lead with the ST elevation. So it's also important to note that reciprocal leads can only be used if they are on the same plane, meaning that the hexaxial leads, or leads 1, 2, 3, AVL, AVR, and AVF, they can only hang out with hexaxial leads. This means that hexaxial leads can only be reciprocals for each other, and the same goes for precordial leads that are hanging out this way, they're looking this way, they can only hang out with precordial leads. So remember that hexaxial leads, precordial leads, they cannot be reciprocals of each other. So now a little exercise I'm going to do is I'm going to list the main types of myocardial infarctions that are associated with certain arteries, coronary arteries that we have in our heart. So it would behoove us to memorize this, or at least have a general idea, so when our patient comes in with an acute MI, it's stressful, there's a lot of things going on, we can just whip this information out of our heads and we can use it to better treat our patient. So a blockage in the right coronary artery, shown here, is associated with posterior or inferior infarctions, or any combination of the two. And the left circumflex artery is associated with pillar, or posterior, inferior, lateral, and singular right ventricle infarctions. And lastly, we have the left anterior descending. If this gets blocked, it's known as the widowmaker. It's associated with septal, anterior, and lateral, or any combination of those previously listed. So now we're going to revisit the infarction cheat sheet, and you're going to understand it a little bit more now. You can see that I've outlined the groups of types of MIs that you will see. So the important thing to remember is that if you see spotty 1 or 2 ST or T changes, it may be nothing, but look into it further. Now, if you see some ST changes in one of these groups, in a complete group, then suspect the worst. You likely have some damage on your hands. So for the inferior MI, we're going to see changes in 2, 3, and AVF. For septal MIs, we're going to see changes in leads V1 and V2. For anterior MIs, we're going to see the changes in V3 and V4. And for our lateral MIs, we're going to see changes in 1 AVL, V5, and V6. And also, an interesting one that I recently learned was the high septal MI, which can be a ST or T change in AVL alone. So that's the exception to our little grouping rule that we just mentioned. So another great little clinical nugget for maybe some advanced practitioners that Matt taught me while I was in the emergency department is that if we see ST elevation that is greater in lead 3 than lead 2, if we see an elevated ST segment in lead V1, and if we see an unchanged or depressed ST segment in lead V2, it likely indicates a singular right ventricular MI. So that's just a little clinical nugget for you guys. But let's return to our man. Let's give him the proper care this time. So we find out that we have a man coming in with a possible STEMI. So if you hear code STEMI or an ST elevated MI, we remember that that means there is some possible cardiac death that has already taken place. So time is of the essence. So we receive the patient into the room. He's diaphoretic. He has a massive headache from all that nitroglycerin that they gave him. He's clutching his left shoulder. He's wincing through the oxygen mask. His wife is crying hysterically. what do we do as healthcare providers? Well, because we watched this video, we have a general idea of what's going on. So the healthcare team will actually calmly hook up the patient to monitor their vitals. Remember, this is an important first step. And also remember that there's going to be a flood of people around here. So a lot of these activities that we're going to discuss are going to be happening simultaneously. So we're going to have some people hook him up to a vital machine, so they're going to get continuous vitals so we can monitor the patient. There's going to be other nurses, healthcare practitioners that are doing IV access with large bore IVs. Another team is going to initiate a 12-lead EKG while using Mona or morphine, oxygen if the O2 sat is less than 95%, nitroglycerin, and anticoagulants as needed. So be sure to strap on some radiolucent pads on your patient's chest and back. And now we see, if we come back to our scenario, that our patient has ST elevation and leads 2-3 AVF and V1 through V6 with reciprocal ST depression and leads 1 in AVL. So this is a massive heart attack that is affecting the inferior, it's affecting the septum, the anterior, and the lateral aspects of the heart. So after confirming with the cath lab that we're good to go, we decide to get some exercise. We are going to rush through the hospital as fast as we can, and we are going to metaphorically and safely throw our patient onto the table. We provide privacy, and then we're going to use scissors to shear off all of their clothes so that the cath team can enter through a femoral vessel and place a stent in our patient so that the injured and ischemic cardiac cells can be paid in blood. So I know that was a lot. I know that's intense. I know there's a lot of things happening all at once, but this can happen quite often depending on where you work, especially in America or more developed countries where we have smoking, hypertension, atherosclerotic disease, recreational drug use like cocaine. But after all this, we're going to be glad that we took the time to learn about acute myocardial infarctions, what they look like on the EKG, and some of the actions that you should expect to do if you're called in to a code STEMI. So as always, thank you so much for taking the time to learn with us today, and remember to like and subscribe for more content.